What's up, Ninja Nerds? In this video today, we're going to be talking about hypertension. So we have to go through a bunch of different things. Let's start off first by defining hypertension. There's a lot of different guidelines out there. There's like the J&C, but I think one of the best ones out there is the American Heart Association. I think it's just pretty straightforward and it gives us a good indication of what we can actually utilize as a definition of hypertension or high blood pressure. So the American Heart Association, they actually suggest that whenever you're taking and considering diagnosing a patient with hypertension based upon these particular numbers, you want to utilize the average of 2 readings on 2 separate visits. That's very, very important. Now, when we talk about these numbers, we utilize 2 particular types of parameters. We use the systolic blood pressure, which is the pressure whenever the ventricles are in systole during contraction. And then the diastolic blood pressure, which is whenever the ventricles are in relaxation or diastole. So what we talk about here is there's different stages or levels of, if we will, normal, elevated, stage 1, stage 2 hypertension or high blood pressure. Normal is less than 120 over less than 80. So whenever you have someone who's less than 120 systolic and less than 80 diastolic, that's considered normal. Whenever they have it between 120 to 129 over 80 to 89, then we're considering that to be somewhere around the elevated blood pressure range. Whenever it's 130 to 139 over 80 to 89, then you're getting in that stage 1 hypertension range. And then last but not least, whenever you're greater than 140 over greater than 90, that is again considered to be a stage 2 hypertension. It's important to remember that you can have what's called isolated systolic hypertension. So in other words, patients will have any one of these numbers. So if let's say, for example, that they have a blood pressure of 135 over 74. If that's the case, the systolic blood pressure is elevated, but the diastolic is considered to be normal. That is considered an isolated systolic hypertension. And then stage 1, if you will. If, for example, let's say that their systolic blood pressure was 110, but their diastolic blood pressure was, let's just go ahead and say 92. That means that their diastolic blood pressure is in the stage 2 hypertension range. So that could be what's considered isolated diastolic hypertension. So these numbers can kind of just bounce around, but I think one of the biggest things to think about here, easiest one to remember, is if you're greater than 140 over 90, that's pretty good at being able to say this person has hypertension, especially if it's the average of 2 readings on 2 separate visits. The other thing to think about here is that sometimes patients can actually have what's called white coat hypertension or masked hypertension. So white coat hypertension is basically when they only have high blood pressure when they come into the office, but at home or everywhere else, it's completely normal. And so what we want to consider in these patients is what's called a 24-hour ambulatory blood pressure monitoring. And this will tell us their blood pressure, their average blood pressure over the night, during the day, when they wake up. And that's a really good way of being able to rule out any true types of white coat hypertension. The other one is someone can have masked hypertension. It's the exact opposite of white coat, where their blood pressure is actually normal when they're in the office, but skyrocket high when they're outside of the office. And so again, a 24-hour ambulatory blood pressure monitor would be the gold standard for being able to rule out masked hypertension, white coat hypertension, and truly diagnose someone with classic hypertension. All right. So we got our definitions out of the way. A patient comes in, they have a blood pressure greater than 140 over 90, okay, on 2 readings, average of 2 readings on 2 separate visits, or on ambulatory blood pressure monitoring. We have to start thinking about what is the underlying cause. This is where the bang for your buck comes in the actual USMLE Step 2 exams. You really need to know this stuff. So the first one is essential or primary hypertension. This is the most common type of hypertension. It accounts for about 95% of most of the cases. So whenever you present it in your clinical vignette, it's most likely essential hypertension. Now, when we talk about these, there's a bunch of different risk factors, and we'll go through some of the theoretical mechanisms by which these risk factors actually can cause high blood pressure. But one of the biggest things to remember is that it's most common in the age ranges of 25 to 50. Sometimes people will say 55 years of age, but 25 to 50 years of age, and having a family history is a very strong indicator that this is probably someone with essential or primary hypertension. What's the underlying mechanisms or reasons behind someone having essential hypertension? Let's talk about that for just a second. All right, so first thing, we can say that there might be some particular increased sympathetic nervous system activity. Why the heck does this matter? So sometimes when people have an increased sympathetic activity, they're releasing lots of norepinephrine, lots of epinephrine, and actually out of those synapses, they can act on different areas of the body. So one of them, they can act on the heart. When they act on the heart, you know that whenever epinephrine and norepinephrine bind onto the beta receptors, they can jack up the heart rate. And so if you increase your heart rate, we know that there's the formula cardiac output is equal to heart rate times stroke volume. So if heart rate goes up, so does cardiac output. And then we also know That MAP, or your blood pressure, is equal to the cardiac output times your peripheral resistance. So if cardiac output goes up, so does blood pressure. So whenever your sympathetic activity is increased in people who are very, very stressed, type A personality individuals like myself, they may have these higher heart rates and higher blood pressure subsequently. Also, you know, particularly whenever you have a lot of that epinephrine binding onto the myocardial, the contractile cells, it increases the contractility, and then they pump more blood out, so their stroke volume increases. If their stroke volume increases, cardiac output increases and blood pressure increases. Also, whenever someone has a lot of sympathetic activity, it also releases epinephrine, norepinephrine onto the alpha-1 receptors of our blood vessels and causes those suckers to vasoconstrict. If they constrict, what happens to the resistance to blood flow? It increases. If resistance goes up, what does that do to the blood pressure? It increases the blood pressure. And so these patients also have an increased blood pressure by that mechanism. The last thing is that whenever there's lots of epinephrine, norepinephrine, they can stimulate the cells in our kidney, the JG cells, to secrete and pop out renin. Renin is an important molecule that increases the production of a very important molecule called angiotensin II. Angiotensin II does a bunch of different things. We'll talk about it a little bit later in this diagram over here, but it works to be able to increase our blood pressure. So if someone has any particular risk factors that increase their sympathetic nervous system activity, such as like an obesity or in situations of high stress, these can actually cause, again, high sympathetic levels, increasing heart rate, stroke volume, vasoconstriction, and the renin-angiotensin-aldosterone system. All of these can increase the patient's blood pressure. The other mechanism by which people believe that there actually can be hypertension essentially is that there's an increase in renin release. If you have an increase in renin release, this can increase angiotensin II and increase your blood pressure. And they actually see this a lot in patients who are actual diabetics, high insulin levels. So type 2 diabetic patients or obese patients who have high amounts of insulin, they may have an increase in the renin-angiotensin-aldosterone system. The last one here is high sodium retention. So in some patients, they may actually retain a lot of sodium. So they don't excrete a lot of sodium, they retain it. If their sodium increases in the blood volume, in the bloodstream, it pulls in more water into the bloodstream. And that increases your intravascular blood volume. And that will increase your blood pressure. You know what high blood pressure does to the kidneys? Well, what happens is the kidneys think, oh, the blood pressure's high, I can probably get rid of, not release renin, because I don't need to actually increase the blood pressure. Because whenever renin goes up, what does it do to your blood pressure? It increases it. If our blood pressure is already high because we're retaining sodium, that shuts off the renin production. And so sometimes these patients who have high sodium retention and have low renin, we call this low renin hypertension. This is extremely common in African American individuals. They have low renin hypertension, so they don't respond to ACE inhibitors and ARBs as well. That's a very important thing to remember as well. The last particular mechanism here is increasing age. As people get older, they start actually causing less elastin to be present within the blood vessels, the thing that gives the vessels a little bit of a stretch and give. And then it also increases the collagen deposition. And collagen does not give much give. It's very, very high tensile, very rigid, and does not let the blood vessels be able to expand or stretch or distend. And so it loses its compliance. If vessels are very, very not compliant or have a decreased compliance, the resistance to blood flow starts increasing. What is that called? Total peripheral resistance. And if the TPR increases, what does that do to the blood pressure? It ups your blood pressure. And so all of these are the underlying mechanisms I'm hoping to make sense of what causes essential hypertension. We don't exactly know the complete exact reason, but we have a suspicion that having old age, high insulin, high alcohol consumption, lots of stress, smoking, increasing weight, increasing sodium diet, high lipids, particularly high LDL and high triglycerides, and decreased activity or sedentary lifestyle may work through some of these 4 mechanisms to be able to increase your blood pressure. And that's the whole basic concept of someone with essential or primary hypertension. So look for these risk factors in the clinical vignette. Look for an old, diabetic, alcoholic, drinking, smoking, someone eating constantly high amounts of sodium and fatty foods, just sitting on the couch eating potato chips. Okay, that's the kind of patients you're gonna wanna think about with essential hypertension in this age range, and if they have a family history that also hits it off as well. All right, let's talk about secondary. All right, so let's talk about secondary hypertension. So we talk about secondary hypertension, how do we think about these, especially in the clinical vignettes? So we obviously know that patients with essential primary hypertension, they're old, they're chunky, they have a high sodium diet, increased alcohol consumption, they're smokers, they're diabetics, sedentary lifestyle, all that stuff like that, family history, 25 to 55 years of age. Those are big things to think about in your clinical vignette if they have some pressure greater than 140/90 on average of 2 blood pressure readings on 2 separate visits, or diagnosed on ambulatory blood pressure monitoring, right? We know that. But let's say we have a patient who maybe doesn't fit in that category. They're younger, right? And that could be less than 30 years of age. It could be less than 25 years of age. Just remember they're young. But here's the big important point here. They're young and they have very sudden onset, severe, and refractory. That's probably the biggest thing. Refractory hypertension. So they're young, sudden onset, severe refractory hypertension. What do I mean by refractory? So let's say they come in, they're like 25 years of age. They come in, they have these very high blood pressure. You put them on one medication, they didn't respond. Put them on another antihypertensive, didn't respond. Third one didn't respond. Now you have to put them on a fourth one, and they're still struggling to keep their blood pressure under control. In that situation, you really need to start thinking about secondary causes of their hypertension and not it being essential or primary hypertension. That's a big thing to think about here, okay? Now, it's important to remember that they're not very common. They only account for about 5% of those cases with hypertension. What are the things that you need to be thinking about? The first one, most important diseases that can cause hypertension secondarily is renal disorders. This is a huge one. So first thing to think about is there a renal vascular problem? And there's 2 renal vascular issues that I want you guys to think about. And that is fibromuscular dysplasia and renal artery stenosis. Big thing to think about is usually young women are more predisposed to fibromuscular dysplasia. When you have these patients, what happens with renal vascular problems is that these have some reduction in renal blood flow. So they're not getting enough perfusion into the kidneys, whether there's a big fat plaque that's reducing the blood flow or whether there's this weird type of dysplasia of the vessels that's reducing renal blood flow. Whenever there's a reduction in renal blood flow into the kidneys, you know the JG cells, they pick up the renal blood flow. If there's little renal blood flow, they say, whew, low renal blood flow, must be low blood pressure, I'm gonna release renin. When renin gets released, remember it gets converted eventually, or it actually leads to the formation of angiotensin II. And we know that angiotensin II, through a mechanism we haven't discussed just yet, increases blood pressure. That's the big thing I want you to think about. So think about fibromuscular dysplasia, young women, and renal artery stenosis. These are poor renal blood flow issues that lead to secondary hypertension. Okay, the other one are more of like the smaller vessels or renal parenchyma, so a disease of the kidney tissue or the small little vessels in the kidneys that are actually becoming damaged or injured. This would be diabetic nephropathy, that's a big one, polycystic kidney disease, less common, and glomerulonephritis, probably the least common. But I definitely wouldn't don't put aside someone who has end-stage, like very uncontrolled diabetes mellitus and has chronic kidney disease because of this. In these conditions, they're damaging the kidneys, right? Whenever there has so much damage to the actual kidney tubules or the glomeruli, you really cause a reduction in their glomerular filtration rate. They have an inability to be able to filter things out of their glomeruli into the kidney tubules. Because of that, low GFRs actually cause a triggering of the JG cells to say, hey, low GFR, we must have some low blood pressure. We got to perfuse the kidneys better, increase renin production. And so it causes a bump in renin. Renin then leads to the formation of angiotensin II, and angiotensin II, through mechanisms we haven't just discussed yet, increases your blood pressure. These are the big things that I need you guys to think about. So think about these particular renal disorders whenever somebody comes in who's young, severe, sudden, refractory hypertension. What I want to talk about next here is how exactly, just very quickly, so we have an underlying understanding here, how exactly does angiotensin II actually increase our blood pressure? All right, so I'll start here with the increased angiotensin II. How exactly does this increase blood pressure? That's a good question, right? I'm glad you asked. So whenever you have high angiotensin II, it acts directly on the vessels. There's these little angiotensin II receptors on the vessels. And when it binds onto it, it says, hey vessel, you better clamp down, baby. And the vessel will start vasoconstricting very intensely. When it vasoconstricts, it reduces the diameter of blood flow through that vessel. And that increases the resistance. If resistance goes up, that increases your pressure. So that's one way. The second one is it tells your adrenal gland, hey, I need a little bit of aldosterone out here. And so it tells aldosterone, hey, get out there. Come on, get to work, buddy. Aldosterone works to be able to act on the kidneys to increase your sodium retention and your water retention. So it actually reabsorbs more sodium, reabsorbs more water into the bloodstream, and that increases your blood volume and increases your blood pressure. As a secondary thing, just remember later, it also trashes potassium into the urine. So it actually causes potassium excretion and sodium reabsorption, increasing your water inside of the bloodstream and then increasing blood volume, increasing blood pressure. It also works on the posterior pituitary and tells the posterior pituitary, hey, make some ADH. Because ADH works on the kidneys and increases water reabsorption into the bloodstream. More water in the bloodstream, more volume, more pressure. This is the way angiotensin II works to be able to increase our blood pressure, which is a very prominent thing whenever you have some type of underlying renal disease, such as, please don't forget, fibromuscular dysplasia, young women, renal artery stenosis, diabetic nephropathy is a huge one, and then also don't forget about polycystic kidney disease and glomerulonephritis. Now let's talk about some of the other causes that you want to be thinking about, drug-related causes. So these, I think a big one to remember here is sympathomimetics. So anybody who's doing a little bit of booger sugar, the cocaine, NMDA, amphetamines, also those drugs that we utilize to treat patients with ADHD, so Ritalin, Adderall, things of that nature, they also can be considered to be sympathomimetics or PCP. Any of these drugs, but I would put a little bit of an emphasis more on cocaine, especially in your clinical vignettes, especially if you have a patient who has epistaxis and maybe some tremors, think about that, and they're tachycardic. What happens with sympathomimetics is that these work to increase your sympathetic nervous system activity, guys. If you increase your sympathetic activity, cocaine is going to work to increase your heart rate, increase some of the contractility of your heart. If that happens, you increase heart rate and stroke volume, you increase cardiac output. If you increase cardiac output, you increase blood pressure. But please don't forget about an increase in heart rate and a patient who maybe has some nosebleeds, some tremors, and they also have hypertension. That might be a clinical vignette that presents as a patient who has secondary hypertension due to cocaine. But also, high amounts of sympathetic activity work on the vessels and cause the tone to be increased. They constrict more. If they constrict more, they reduce the actual blood flow through the vessel and increase resistance, which also increases your pressure. So don't forget about sympathomimetics as a potential cause. The other one here, which is really interesting, is oral contraceptives. But we have to be very, very specific. If a patient in the clinical vignette is on an oral contraceptive that has to contain estrogen in it, that's the real particular molecule. Or if they're pregnant. What happens is estrogen is really interesting. It works on the liver and increases the production of angiotensinogen. Why is that pretty important? Because you know what angiotensinogen is? It's a precursor. Renin acts on angiotensinogen and converts it into angiotensin 1. Then angiotensin 1 eventually gets converted into angiotensin 2. And then angiotensin 2 does what? Does all these mechanisms to increase your blood pressure. So that's where you can get this in patients who are pregnant because of the high estrogen levels during pregnancy, but more specifically in the clinical vignette, a young patient who was on estrogen-containing oral contraceptives. The last one here is a very common drug that is very commonly utilized in pain and fevers. It's your NSAIDs, the ones that particularly inhibit this enzyme called COX-2, cyclooxygenase. Keep your minds clear. Whenever the macula densa cells in the distal convoluted tubule, you know what they do? They release a molecule called PGI2 or prostacyclin. What prostacyclin does is it works to be able to tell the afferent arteriole to undergo vasodilation so that we can have good renal blood flow into there. What happens is when someone takes NSAIDs, they inhibit this enzyme, the cyclooxygenase. Guess what cyclooxygenase does? It's responsible for helping to form prostacyclin. If you give someone NSAIDs, you inhibit the cyclooxygenase, you inhibit the formation of prostacyclin. Can you vasodilate your afferent arteriole? No. And so subsequently it constricts. Then you reduce the renal blood flow into the actual glomerulus, less filtration across the glomerulus. If there's less filtration, guess what you don't actually filter across? Sodium. And so you retain the dang sodium. And then water follows. And that increases your blood volume and increases your blood pressure. The other thing is if you reduce your GFR, what did we say that also did up here with these diseases? Whenever there's a reduction in GFR, it's viewed as though there's low perfusion to the kidney. And so maybe the blood pressure is lower. And so what happens is this bumps up your renin production. And then renin leads to angiotensin 2. Angiotensin 2 works to increase your blood pressure through all these mechanisms we just discussed. So big things to think about is renal diseases, Drug-related causes, don't forget sympathomimetics with a real emphasis on cocaine, estrogen-containing oral contraceptives, and NSAIDs. All right, engineers, let's move on to the next part, which is another big one, particularly endocrine causes. All right, so the next thing is endocrine causes. So what are the things that you should be thinking about? All right, so first one is think about your adrenal glands. So we had the kidneys, then we had some drugs, then we're gonna think about the endocrine causes. Start with your adrenal glands first. Adrenal glands, they make a lot of different hormones that regulate our blood pressure. Big ones to think about is aldosterone, cortisol, and norepinephrine, epinephrine. All right, so let's go through those in order. What if a patient has a disease where they make too much aldosterone, hyperaldosteronism, like maybe they have a tumor of their adrenal cortex or something, and they're just blasting out aldosterone? What could that happen? What could actually result from that? How does that work? If someone's making a lot of aldosterone, they're going to increase their sodium and water reabsorption in the bloodstream and increase their blood volume, increase their blood pressure. That makes sense, right? But what would you want to think about in these patients as well? Just to think about this when we get into the actual putting it all together with a diagnostic test. What does aldosterone do? Reabsorb sodium in the blood and excretes potassium. So what do you think would happen to the potassium levels within their blood? They'd have low potassium, high sodium, and high blood pressure. That's a big thing to think about. The other thing is aldosterone also trashes protons in the blood too. So if you're trashing protons in the blood, what would that also do to your actual pH? If you're getting rid of protons, so protons are decreasing, then what's going to happen to the pH? The pH will go up, and that's an alkalosis. So it can also cause a metabolic alkalosis. So don't forget that in that clinical vignette. All right, that's one particular reason. The second one is that there's a lot of cortisol. So you know there's a disease called Cushing syndrome. So they have like they have a moon face, they have like a buffalo hump, they got the abdominal striae, they got like very thin bones. A lot of those kind of patients who present like that with the moon face, the swollen, like the buffalo hump, a lot of the moon faces, again, abdominal striae, very thin bones. And those patients who have a lot of cortisol within their bloodstream, cortisol works to increase the actual sensitivity of the sympathetic nervous system. So you know whenever epinephrine, norepinephrine bind onto beta receptors and alpha receptors, cortisol makes those receptors more sensitive to the epinephrine and norepinephrine. So what happens is every time epinephrine and norepinephrine bind to any type of alpha and beta receptor, all their activities are accentuated. It's all increased. So they would increase your heart rate, increase the contractility of the actual heart, and cause the vessels to constrict more. And that would all increase your blood pressure. So again, think about that with Cushing syndrome. A patient who has a moon face, a buffalo hump, abdominal, a very, very large abdomen with kind of like the striae and very thin kind of bones. The next one is a pheochromocytoma, another adrenal issue, but this is a problem with epinephrine and norepinephrine. They have a tumor of their adrenal medulla, which is blasting out tons of epinephrine and norepinephrine. When that happens, that increases all the sympathetic activity. Your heart rate goes up, your contractility goes up, the constriction on your vessels go up. All of those things increase your blood pressure. Think about this in a patient who presents with like these paroxysmal episodes of super high blood pressure, uncontrolled, very terrible headaches, palpitations. You know what else the sympathetic nervous system does to your blood glucose levels? They jack it up. And so their blood sugar levels will also be high. They could also be high in the cortisol one too, Cushing syndrome. So don't forget these kinds of things. A patient presents with very terrible headache, they present with palpitations and very super high blood pressure that's refractory to meds. Think about pheochromocytoma. All right. We got our adrenal gland issues. All right, so now that we talked about the adrenal issues, let's talk about the thyroid issues. So believe it or not, it's weird, but both hyper and hypothyroidism can cause hypertension. Now, how does it actually do this? So hyperthyroidism, remember, it primarily kind of works to increase the actual heart activity. I think that's the best way to remember it. So it increases a lot of the heart activity. It works really by kind of increasing the activity of your beta receptors on the heart. And so whenever the sympathetic nervous system, like epinephrine, norepinephrine, like those hormones bind onto those receptors, their activity is amplified on the beta receptors. And so they would increase the heart rate, which would cause the heart rate to go up. It would increase your cardiac output and then subsequently your blood pressure. And would also increase the contractility of the heart. So if the heart's contracting more, you're gonna have a higher stroke volume and increase your cardiac output, increase your blood pressure. Now, what's important to remember though, is that it doesn't have it actually kind of like very weirdly can decrease tone within the vessels. So now think about that. If someone has hypothyroidism, they have a decrease in their thyroid hormone, decrease in T3 and T4. What happens is if in hyper, it actually decreases tone, in hypo, it's going to increase the tone of the vessels. If the tone of the vessels is really, really increased in situations of hypothyroidism, if you're squeezing the vessels, you're reducing the diameter and increasing the resistance to blood flow, that's going to increase the total peripheral resistance and increase your blood pressure. I know it's pretty wonky, but that's the way it works. So easy way I like to remember it is hyperthyroidism. It's you're increasing the activity of the heart, but it actually decreases the tone of the vessels. Hypothyroidism, you're increasing the tone of the vessels. Easy way to remember it that way. Last but not least, my friends, is hyperparathyroidism. So we talked about the adrenals, we talked about the thyroid, and now we're going to talk about the parathyroids. So in patients who have hyperparathyroidism, their parathyroid glands are just blasting out tons of PTH. Why is that a problem? Because PTH works to increase the calcium levels within the bloodstream. If there's lots of calcium within the bloodstream, that can get actually flushed into these smooth muscle cells of the vessels. If you flush calcium into the smooth muscle cells, what are they going to do? They're going to cause increased contraction. If the vessels actually contract and vasoconstrict, that reduces the diameter, and that increases the resistance to blood flow, and therefore subsequently increases the blood pressure. And so that's a big thing to remember here is, again, increased calcium, increase your total peripheral resistance, and that'll work to increase your blood pressure, my friends. All right, so that will cover all of the endocrine causes. So again, we talked about renal causes, fibromuscular, renal artery stenosis, diabetic nephropathy, we talked about polycystic kidney disease, we talked about glomerulonephritis, all the drugs, think about cocaine, estrogen-containing oral contraceptives, NSAIDs. Then we talked about hyperaldosteronism, Cushing's syndrome, pheochromocytoma, hyper and hypothyroidism, and lastly, hyperparathyroidism. Now let's move into some cardiac causes. All right, so the next one here is going to be your cardiac causes. So when we talk about this one, big one to think about is coarctation of the aorta. So coarctation of the aorta is a very interesting one. So you can see this in adults who have particularly a coarcted aorta over a long period of time. What happens is a coarctation of the aorta is kind of like this very, very narrowing or stenosis of a part of the aorta. Right? So imagine here that blood is trying to leave from the left ventricle going out into the aorta, and from the aorta it can actually go up through all the vessels of your aortic arch, but then afterwards it's supposed to go down the descending aorta to go and supply like your lower extremities. Obviously the branches that come off the aortic arch will supply a lot of the upper extremities, the head and the neck. So imagine that just after that actual branch, all these like branches off the aortic arch, you have this very, very significant narrowing right there, and then it reduces a lot of the blood flow that's going to be able to go down the descending aorta. That's going to be an issue, right? Because if you can imagine here, there's an obstruction right here. There's an obstruction to blood flow right there at that portion where it's super, super stenotic and narrowed. What that's going to do is an obstruction to blood flow is going to increase the blood pressure proximal to that obstruction. So all the blood pressure will be super high going to your upper extremities, going up into the head and the neck. But then the obstruction after, like when you go distal to the obstruction, after that narrowing, after that stenosis, going down into the lower extremities, the blood pressure in that area is going to be reduced distal to the obstruction. And so their blood pressure in their lower extremities will be a lot lower. Also, think about this. If you have a high blood pressure and you have a lot of blood slamming through the actual vessels of the head and the neck and the upper extremities, the pulses are going to be super bounding and way more intense in the upper extremities, head and neck area, and they'll be way more diminished or decreased in the lower extremity areas. That's another big thing to be thinking about in these patients. Now, here's what's really important. If you measure their upper extremity blood pressures, they could be very high. And if you compare to the lower extremities, they'll be a lot lower. But here's the next thing to think about. If you have a decrease in the actual blood pressure distal to that obstruction, that means that you have less blood flow to the kidneys, because you're going to have a reduction of blood flow going past that obstruction. If there's less perfusion to the kidneys, what does the kidneys take that as? There's low blood pressure. And so they release renin. And if the renin is released, what does that do? Increase in renin increases the activation and formation of angiotensin II. Angiotensin II works to increase your blood pressure. So you can increase your blood pressure by two ways. One is they have this obstruction cause the blood pressure proximal to that obstruction, cause very, very high upper extremity head and neck pressures. But also because of the reduced flow distal to that obstruction, you don't perfuse the kidneys as well. And because of that, they release renin and cause angiotensin II to build up and therefore cause hypertension. So that's your cardiac causes that you want to think about as a secondary cause. All right, so think about this in a patient who has very strong pulses of the actual brachial radial arteries, and they come way before the actual femoral arteries, or their pressure in the upper extremities are way higher than the pressure in their lower extremities. Think about that in these patients. All right, pulmonary causes. This is a very, very important one and very significantly on the rise now. And this is obstructive sleep apnea. The mechanisms can be quite complicated, so I'm not going to go into crazy detail. But what I want you to know is when a patient has obstructive sleep apnea, they stop breathing. So they go into this apneic or hypopneic period where they don't take in air and they don't exhale air. And so if they don't take air in, their oxygen levels in the blood will decrease. And if they don't exhale air out, their CO2 levels within the blood will increase. So this can cause hypoxemia and hypercapnia. When that happens, one of the biggest things is it really ramps up your sympathetic nervous system. And your sympathetic nervous system tries to increase your heart rate, it tries to increase the contractility of your heart, and it tries to increase the tone of your vessels. And all of that will work to increase your blood pressure. It also can cause oxidative stress mechanisms and inflammation. I don't want you to get too crazy. I want you to know that those are present, but focus more on how this apneic period that causes a drop in oxygen, increase in CO2, increases your sympathetic nervous system, which increases your heart rate, your contractility, and the squeeze on your vessels, which increases your blood pressure. So think about that, an obese patient who snores a lot at night, wakes up with a terrible headache, and then again is very tired and lethargic throughout the day. All right, so let's talk about some neurological causes. These are really interesting. So, whenever a patient has high intracranial pressure, there's something called the Cushing's triad. And one of the components of that is the one that we care about. Whenever there's high intracranial pressure, it actually causes a reflexive increase in your blood pressure. The mechanisms aren't super clear on this, but that's something that we definitely know there's a relationship with. So as intracranial pressure increases, we see that blood pressure also proportionally increases. This is a part of something that you should know called the Cushing's triad. So the Cushing's triad is when someone has high blood pressure, bradycardia, so low heart rate, and irregular or sporadic or kind of like weird respiratory patterns, okay? But again, hypertension, bradycardia, and irregular respirations are the key features of Cushing's triad. So how would they present this in the clinical vignette? Let's say that you had a patient who has high intracranial pressure. So what will they look like? Maybe they have some type of blood within the brain, right? They have blood in the brain, and that blood in the brain is going to accumulate because, the skull is a fixed cavity. So if brain fluid, if any brain blood or fluid increases, the pressure inside of that skull increases. So if you get lots of blood, like you have a hemorrhage inside of the brain, that could cause increasing intracranial pressure. If they have some type of mass, so lots of brain tissue now, they have like a brain mass or they have an abscess, that's going to increase the space inside of the skull and increase pressure. Or if they have lots of fluid, like lots of edema. And patients who have lots of edema for some reason, but lots of fluid, maybe they had a very large stroke and now that area is infarcting and causing a lot of fluid to leak out, that also can increase the space inside of the brain, increasing intracranial pressure. So if someone has a severe neurological injury on their clinical vignette and they present with hypertension, bradycardia, and irregular respirations, think about that as a secondary cause of their actual newly found hypertension or refractory hypertension, okay? All right, so that's your neurological causes. The last one that I really want you guys to think about and don't forget is pregnancy. We don't know the exact mechanism, so I don't have anything to actually explain how this happens. It may be related to estrogen and placental perfusion and stuff like that, but we don't have a complete idea, so I don't even want to waste your time trying to memorize it. But there's two particular conditions to think about in pregnancy: preeclampsia and eclampsia. And patients who are greater than 20 weeks, okay, within their gestational period, they're at high risk of preeclampsia and eclampsia. Big difference between them is both of them have high blood pressure, both of them have proteinuria. The bigger difference here is that in patients with eclampsia, they also have seizures. And so this is something to think about. If you have a patient who is pregnant, greater than 20 weeks, they have high blood pressure, protein in their urine, you can think about preeclampsia. And if they're seizing, you think about eclampsia. And those could be causes for their secondary hypertension. Ninja, as we covered all the causes, let's now move into what are some complications from very high blood pressure over time or super high rises in blood pressure very acutely. All right, so now let's talk about the complications. So when we talk about the complications of hypertension, this could be chronic over a long period of time, or you can also see this whenever somebody has like acute rises in blood pressure, just very, very high rises in blood pressure. So what could this look like? So there's different systems that we want to focus on. The big one I want to talk about is neurologically. So let's start from the top, work our way down. So brain-wise, what can happen whenever you have like this chronic hypertension over time or super, super acute rises in blood pressure? One of the big things to think about is it can actually cause a lot of stress on those vessels, right? It can put a lot of shearing forces on the vessel walls and cause them to actually expand, dilate, or even potentially rupture. That's a problematic issue. So what you want to think about is, let's say that you actually get like this ballooning of the vessels. If you get ballooning of the vessels, that's called an aneurysm, right? So you can actually have these different things called berry aneurysms, which are whenever some of the actual vessels kind of form like this little saccular type of aneurysm in it, and those can rupture. When they rupture, blood can leak into the subarachnoid spaces and cause a subarachnoid hemorrhage. That's a big thing to think about. If a patient has a subarachnoid hemorrhage, look and see what their actual initial or presenting blood pressure was. Second thing, you know, there's these little areas here, you know what's called your MCA. Coming off the MCA, there's these tiny little vessels called the lenticular striae vessels. And sometimes whenever those are under a lot of high pressure, a lot of shearing forces, they can also form tiny little aneurysms that can also rupture into the area of like the, particularly like the basal ganglia, like the caudate nucleus, you have your putamen, your globus pallidus, all those good things there. It can rupture into those areas. And those little aneurysms that you can see coming off the lenticular striates are called Charcot-Burchard aneurysms. And whenever those happen, they can cause bleeds inside of the actual parenchyma of the brain, which we call an intracerebral or intraparenchymal hemorrhage. The other thing to think about, whenever people have super high blood pressure, it can actually alter the capillaries where they lose their ability to maintain the balance of fluid moving in and out of the blood vessel. And so fluid can actually start leaking outside of the actual capillaries and cause edema, very specifically in the posterior portion of the brain. And so this can cause what's called posterior reversible encephalopathy type of syndrome, PRES. And this can be seen very particularly on MRI, but it's just due to a lot of pressure causing a lot of edema and a lot of fluid to leak out of those capillaries. Sometimes it can even cause hemorrhage as well. So these are the big things: subarachnoid hemorrhage due to a berry aneurysm, ICH due to Charcot-Burchard aneurysms, and PRES due to a lot of vasogenic edema. The other thing that can happen, especially with chronic, long-standing hypertension, is these vessels, the tiny little vessels that actually supply a lot of the areas of your basal ganglia, your midbrain, your pons, your cerebellum. What can happen is sometimes they can actually get really thick because of high pressure over a long period of time. They have to accommodate. Because what happens is with high pressure, you're increasing the risk of those actual blood vessels rupturing. And so what happens is those tiny little blood vessels, they decide to accommodate for that high pressure and get thicker, more thick-walled. And because they become more thick-walled, it actually kind of makes the lumen really small because they have to get thick to accommodate the pressure, but then unfortunately they reduce the blood flow through that tiny little lumen. And now if you can't get a good amount of blood flow and oxygen delivery to the tissues of the brain, what can happen? You can develop an infarct or a stroke. And so this is actually very commonly called lacunar infarcts. Very tiny, small subcortical infarcts that involve like your internal capsule, your basal ganglia area. So that's an important thing to remember. These are your subcortical strokes. So you can see subcortical strokes, subarachnoid hemorrhages, ICHs, and PRES. How would this patient present? They come in with a super high blood pressure and they present now with let's say that they have a neurodeficit. They have weakness on one side, sensory changes on one side, a facial droop. They are seizing, right? They have an altered mental status. They're confused. They're obtunded. These are particular findings that we would want to think about that could be evidence of some type of neurological injury as a result of the high blood pressure. All right, so what are the complications next that you can see with the retina? So if someone's coming in, they got like blurry vision or they got decreased vision, get your fundoscope and take a look in the eye, right? You got to use that good old tool that we utilize in medical school and PA schools, right? So what you want to do is you want to see, okay, whenever you're looking at the retina, one of the first signs, stage 1 signs, could be AV nicking, arteriovenous nicking. What happens is whenever you have a high blood pressure, those arteries can kind of get thicker and can push down on the nearby veins and kind of compress them and make them look blind-ended at one point. And so that's called arteriovenous nicking. The other thing is, whenever you have these actual small vessels under high pressure, they can form little aneurysms and they can rupture. So you can get tiny little like microhemorrhages. Also, some of the fluid can actually leak out of these vessels too because of the high pressure, and that can be called exudates. And sometimes in the area where you have all these exudates and hemorrhages, you can kind of get infarction of the actual retinal tissue, and those are called your cotton wool spots. The other thing is that whenever there's high blood pressure over a long period of time, that can actually cause like problematic issues here. It can cause the swelling of the optic disc. And whenever the optic disc gets really swollen, it blurs the margins. This is a very important finding called papilla edema. So blurring or swelling of the optic disc when you're looking at it under fundoscopy is a very concerning sign. So you want to be able to recognize that as well. All right, so cardiac issues. So obviously one of the big complications is whenever you have someone who has hypertension, it can increase the risk of atherosclerosis, right? So plaques that can develop within vessels. One of the big vessels that you gotta be concerned about, unfortunately, is the vessels in the heart, so the coronary vessels. So they can form plaques as a result of chronic hypertension. But the other concerning finding that you can have here is that whenever someone has hypertension, their actual heart has to work a little bit harder because they have a reduction in blood flow, but their heart might have to work harder. And so there can sometimes be like a demand type of ischemia. The other thing that can happen here is that you can actually have enough pressure that it ruptures or fissures the actual covering of the plaque and increases the risk of a thrombus forming on top of that. Either way, the whole point here that you have to be thinking about is whether there's a stable plaque or whether there's an unstable plaque that ruptures and a clot forms on top of it, there can be a reduction in blood flow due to chronic hypertension. When there is a reduction in blood flow to the myocardium of the heart, less oxygen is delivered to the myocardium. The myocardium can become ischemic, and over time that ischemia can lead to possibly infarction. So one of the classic types of complications is a patient who presents with like coronary artery disease. And this is a range. So a patient can present with an NSTEMI, they can present with a STEMI, or they may even present with maybe just like some type of angina. This could be unstable or stable angina. So it's important to be able to remember that. So be recognizing these particular types of issues. If a patient comes in and they're presenting with ischemic chest pain, that classic findings of ischemic chest pain, you should consider, they're hypertensive. Maybe this could also be causing some type of issue here with the myocardium of the heart, particularly reducing the coronary blood flow by forming plaques, causing rupturing of the plaques, reducing blood flow, increasing the demand of the heart. The next one here is that whenever somebody has chronic hypertension, high blood pressure over time, what happens is, imagine here the pressure inside of the aorta is really high. Okay? Pressure inside of the aorta is really high. That means that the pressure that the left ventricle has to exert or generate has to be higher than the pressure within the aorta to push enough blood out of it, right? We know that. So we need high pressure in the left ventricle and a lower pressure in the aorta for us to push enough blood out of the left ventricle. But let's say that the pressure inside of the aorta is getting really, really high. And now the left ventricle is struggling to be able to get a pressure high enough to actually push blood out. What it'll actually do, because you're having a higher afterload, now you're making the work that the left ventricle has to do to push blood out of the heart, it's going to be a lot more. So that's going to increase your afterload because of a chronic hypertension in the aorta. What happens is the left ventricle compensates and says, the pressure's really high, I can't maintain a high enough pressure to push blood out. I'm gonna thicken this bad boy. And it thickens up and hypertrophies that left ventricle. So it gets bigger and stronger and able to generate more force and more power to push blood out of the left ventricle. But subsequently, if you make this thing thicker, you make the actual diameter or the cavity of the left ventricle smaller. Imagine trying to fill that up versus filling that up. Which one do you think would be easier? This side. It's going to be really, really hard to fill up that side because it's very thick and very small diameter ventricle now because you've thickened it up to accommodate for the high pressure. So what happens is when you try to fill these ventricles up and get blood into them, you don't fill them up very, very well. And so that's called diastolic filling. There's a reduction in the diastolic filling because you thickened up the ventricles because of the hypertension. If you decrease their filling, where's the blood going to go now? Can't go into the left ventricle, so it starts backing up. Where does it back up? Into the lungs. And these patients can present with some type of fluid in the lungs called pulmonary edema. So they may present with dyspnea, shortness of breath. So that's another big thing. And in acute hypertensive crises, they can present with flash pulmonary edema. Very, very high types of pressures can actually push blood back into the lungs. And that can be a very significant thing to think about. Now, going off of the left ventricular hypertrophy, continue off here, okay? We have a patient who has diastolic heart failure that could be a result of chronic hypertension. But let's think about this. That left ventricle gets very, very hypertrophic and thick. What happens is we want blood to go from the atria into the ventricles, right? We want it naturally to flow in that direction. But whenever the left ventricle is super thick, the pressure inside of the left ventricle is going to be a lot higher. So then the left atrium is like, dang it, I got to push blood down into this high pressure ventricle. I can't push it down. How am I going to be able to do it? It's the exact same issue that the left ventricle had with the aorta. So the left ventricle had to thicken because the aortic pressure was too high. What do you think is going to happen to the left atrium because the left ventricular pressure is too high? It's got to beef up. And so the left atrium undergoes hypertrophy and it thickens up. And when it undergoes that hypertrophy, it alters the electrical activity, because now imagine electrical activity moving through that thick left atrium versus the thin left atrium. It's going to be a lot more difficult to move through that thick left atrium. And so that can cause arrhythmias, increased risk of atrial arrhythmias, with that being atrial fibrillation. So if a patient comes in with some type of neurological injury, again, with hypertension, think about that, or retinal injuries, or some type of cardiac issue such as risk of coronary artery disease, which can span all the gambit of NSTEMI, STEMI, angina, diastolic heart failure, or atrial fibrillation. These are things to think about. The other complication that can come from chronic hypertension or long-standing hypertension is vascular issues. So here's the thing to think about. If a patient has a super acute rise, let's say that they have chronic hypertension in general, they have hypertension. What happens with hypertension, it also kind of weakens the vessel walls. It can cause medial degeneration of the vessel wall. And so they're a little bit weaker. Now imagine for some reason you have an acute rise in blood pressure for whatever reason. Now what happens is that blood that's actually rushing through the lumen, sometimes it can be strong enough, if the vessel's really weak, that it can rip right through the actual tunica intima, the internal lining of the vessel. And when it does that, it dissects into these actual areas and forms like a false lumen, where blood can actually track in another area that's not the lumen of the blood vessel. What is that called when you have high blood pressure so much that it shears and rips the tunica intima and blood dissects into the actual blood vessel wall? That's called an aortic dissection. And so this can happen to patients with chronic hypertension, but also they have a brief acute rise in blood pressure that it actually rips through the tunica intima and causes that issue. All right, so the next one here is an aortic aneurysm. This is another common complication in patients with hypertension. So whenever somebody has very high blood pressure, this puts a lot of stress on the vessel walls, right? So there's a lot of tension on the vessel walls, which causes the vessel to actually kind of dilate or expand in response to that. And so again, whenever there's high blood pressure, it really weakens the vessel wall and increases the diameter of the vessel. And that can become a problematic issue, because if you think about this, think about a thin-walled vessel. As you stretch it out, it gets really, really thin. That's easy for that bad boy to just kind of rupture. And oh my gosh, could you imagine what would happen if that occurred? You could have a massive rupture of a large vessel and you could exsanguinate internally. So that's a very, very scary thing if the aortic aneurysm ruptures. So again, high blood pressure weakens the vessel walls because it puts a lot of shearing forces on the vessels, and it causes a subsequent increase in the diameter of the vessel. You actually know how it does this, very interestingly, not just direct force, but there's tiny little vessels. So if you would actually kind of zoom in on this actual vessel wall, there's tiny little blood vessels that supply the actual blood vessel. They call them vessels on vessels. It's called the vasa vasorum. They're tiny little blood vessels that are actually present in the wall of these big vessels. What happens is, and whenever you have patients with very, very high blood pressure, it causes these tiny little vasa vasorum vessels to get very thick and sclerotic. If they're very thick and sclerotic, imagine blood flow having to squeeze through these tiny little vessels. If they can't deliver oxygen to the actual wall of the vessel, what happens? It starts to die. If these vessels start to die, they get weaker. If they get weaker, they aren't able to maintain their normal shape. And so guess what? That's what really causes the diameter of the vessel wall to get bigger, is because high blood pressure is really thickening the tiny little vasa vasorum vessels that supply the vessel wall. If they get very thick, they reduce blood flow to the vessel wall. It gets weak, damaged, and then starts to dilate. And that can become a very, very problematic issue where it can actually rupture. All right. The last thing that you want to think about is that whenever patients have high blood pressure, chronically high blood pressure, this also is a very significant risk factor for atherosclerosis, right? You damage the vessel wall. Anytime you damage the vessel wall, you increase the risk of causing plaque formation to occur. And what happens is this atherosclerotic plaques that develop within the vessel walls, imagine for a second, just like we said with the heart, where you have a reduction in blood flow. And imagine you're trying to supply blood to the muscles of your lower extremities. If you're exerting yourself and you start having less oxygen being able to squeeze through those tiny little blood vessels into your extremities, what can happen? You can develop a severe pain and weakness of those lower extremities. We call that claudication. And that's very common in patients who have what's called peripheral artery disease. And this is another particular complication that you can see in patients with long-standing or chronic hypertension. All right, what's the last system that we got to talk about? That's renal. Let's go there. All right, so the next thing we got to talk about is the renal system. What are the complications that we can see here? With long-standing hypertension, high blood pressure, again, you thicken the vessels, right? They have to accommodate. So they thicken. So it causes an arteriosclerosis of like the small renal vessels. What happens is, imagine you have to be able to get blood flow, right, through like these renal arteries. And you know the renal arteries, you have like, they come off and they give off what's called the capillaries, and the capillaries are basically going to supply oxygen to the kidney tubules themselves. So the actual renal blood flow, not only does it determine your urine production, but it also supplies the kidney tubules. So whenever there's thickening of these actual small little vessels that are going to be going to your glomerulus, you want to think, yeah, you're going to have less filtration. That's definitely a result here. But also you're going to have less oxygen delivery to the tubular cells. So when there's arteriosclerosis, there's thickening of the vessels, there's a reduction in blood flow. That reduction in blood flow is going to cause the kidney tubules to start becoming ischemic. If you don't fix that or you don't reverse the problem, guess what? They start to die. When they die, they undergo a lot of fibrosis and sclerosis, and they stop functioning. And then the kidneys can actually start to atrophy. And when they atrophy, the kidneys start to fail. When they start to fail, that's a problematic issue, because then it starts to basically worsen the secondary hypertension. Because remember, if kidneys fail, what happens to their GFR? Goes down. What does GFR do to renin? Goes up. If renin increases, so does angiotensin II. If angiotensin II goes up, so does blood pressure. So you can see how hypertension, you can actually have it as a result of a renal disease. But if you don't treat it, that hypertension can continue to damage the kidneys, and if the kidneys get even more damaged, they continue to worsen the hypertension. It's this vicious cycle, my friends. So it's very, very important to realize that. The other thing to think about is that sometimes if people have a super, super high rise in blood pressure, like a super transient acute rise in blood pressure, think about it. That might be enough to actually rupture some of these actual smaller capillaries in the glomerulus and leak some of the components out into the actual urine. One of the big ones is red blood cells. And so sometimes if someone has super high blood pressure, like acutely, you may see a lot of red blood cells in the urine called hematuria. Another thing that actually goes along with renal failure is whenever the kidneys start failing, they actually lose the ability to regulate a very specific protein in their urine. And that big protein that you need to know that you can lose into the urine over time is called albumin. And really, this is called albuminuria. So the protein that's actually in the urine is called albumin. And in patients with very significant renal failure, they can lose a lot of albumin in the urine, and this is called albuminuria. So these are the big things to think about. So again, complication is very significantly renal failure, which you can classify with a lot of albumin in the urine. But I think another thing is with the acute rise is sometimes this can rupture some of the smaller capillaries and actually cause hematuria, sorry. All right. The next thing that we have to talk about is the potential complications of hypertension. Is that maybe somebody decides to not take any of their medications. They're not establishing good control. They have a very significant stress factor that just causes their blood pressure to skyrocket to the point where it actually starts causing some very severe issues. We need to talk about those, and these are called your hypertensive crises. So let's talk about that. All right, so hypertensive crises, there's two different definitions that we have to talk about: hypertensive urgency and hypertensive emergency. So urgency is basically, it's just a number, okay? It doesn't mean anything. It's just you have a systolic blood pressure that's greater than 180 and a diastolic blood pressure that's greater than 120, one or the other. And if that is the case and you don't have any target organ damage, what does that mean? You didn't damage the brain. You have no types of like ICH, subarachnoid hemorrhage. You have no signs of PRES or lacunar infarcts. You don't have any particular damage to the heart, so there's no types of coronary artery disease or heart failure or AFib. And again, we can keep going down. There's no retinal injuries. There's no types of vascular issues like aortic dissection, aortic aneurysm, peripheral artery disease. There's no renal injury. If any of those things are not actually injured, there's no target organs that are damaged as complications of hypertension, then this is considered to be hypertensive urgency. Really important you remember that. It's just a number, no target organ damage. None of the organs that we just mentioned got damaged. Hypertensive emergency, though, is a completely different story, and that's a very, very important one. Hypertensive emergency is when you have high blood pressure, but it's not so much the high blood pressure. Yeah, you can remember greater than 180 over 120, but it's more specifically that they have target organ damage associated with their high blood pressure. What are those target organs? Just to go back, space repetition, let's remember them. Neurological. if they have an ICH, a stroke, a subarachnoid hemorrhage, or PRES. This may present in a ton of different ways. If they have a bleed or a stroke, look for any signs of neurodeficits, weakness on one side, sensory changes, ataxia, cranial nerve palsies. They're lethargic, they're having an altered mental status, they're delirious, they're confused, they're having seizures. Any of those particular findings could be suggestive of target organ damage. Renal. They damaged their kidneys so much that they bled into their actual urine. So they have hematuria on their urinalysis. Or their blood pressure was too high that they injured the kidneys and caused an acute kidney injury. That may also be a thing. So look for a decrease in urine output, an increase in their BUN and their creatinine. Cardiac. Their blood pressure so darn high that their heart's having to work so hard to be able to generate these, to be able to contract and push blood into the aorta. And so it's just pumping so hard that it increases the demand, right? The myocardium's like, dang it, I'm having to work so hard to generate these high pressures to push into the aorta, who's like just super high pressure right now. And if I'm having to work this hard, I need a lot of oxygen. But if they have plaques in their vessel walls, or maybe they don't and they're just having to work really hard, this can cause coronary artery disease to potentially worsen. Maybe they get like a demand ischemia, or maybe they get like an NSTEMI, right? So that's an important thing to remember. Also, if a patient starts to develop acute pulmonary edema, shortness of breath, rails on auscultation, and you get a chest x-ray and you see a ton of pulmonary edema, this could be indicative of an acute left side heart failure, which can also be a result of high blood pressure. Remember I told you, diastolic heart failure. Vascular, you look and they have differences of blood pressure in each arm. They have pain that radiates into their back, right? They got a lot of the actual deficits that can come from an aortic dissection. That's an important thing to be looking for if you see evidence of an aortic dissection. They're AAA ruptures, they're super hypotensive, they have a palpable mass, they are having a lot of abdominal pain. These are big things to be thinking about. And retina, if you get your fundoscope out and you look at their eye and you see any signs of AV nicking, you see cotton wool spots, microhemorrhages, exudates, or papilla edema, then you have evidence of retinal damage, which is one of the target organs. If any of these are damaged and you have a high pressure, we know that you have hypertensive emergency. My friends, now that we covered that, let's talk about the workup, putting all of this together with secondary hypertension. All right, my friends, so now what we gotta do is we gotta put everything together, okay? We gotta really take everything that we learned, good spaced repetition here, and put it all together. So a patient comes in, right, we have to diagnose them with hypertension. If it's essential hypertension, it's relatively simple, right? Look at their risk factors, look at their family history, look at their age, and then again, what else did we say here? What was the numbers that we needed? If we look at the AHA guidelines, we need at least average of 2 readings on 2 separate visits, or you can use the ambulatory blood pressure monitoring. But we said if it's greater than 130 over 80, that's stage 1 hypertension, that's hypertension. Or if it's greater than 140 over 90, that's again stage 2 hypertension. That's your essential or primary hypertension. But if it's secondary, it's those patients who are young, sudden, severe, refractory hypertension on multiple meds, and you still can't get it under control. What are the tests that we should think about to rule out those conditions? And let's just kind of retest all of that stuff, spaced repetition here. So first thing, renal diseases. So you're thinking about renal vascular, fibromuscular dysplasia, you're thinking about renal artery stenosis. Maybe check like a renal ultrasound. That could tell you if you have any polycystic kidney disease. It may even get a Doppler study. If you do a Doppler study, you may be able to show like reduced pulmonary blood flow or show fibromuscular dysplasia. So that's another thing, is whenever you get an ultrasound, it may also show renal artery stenosis, and it may also show fibromuscular dysplasia, so don't forget that. Take your stethoscope, put it over the abdomen. You hear a bruit. Ooh, that could be also the thing that's causing a reduced renal blood flow. If there's kidney damage, then the actual kidney tubules aren't being able to good at maintaining like your BUN, your creatinine. And so what would you expect if there was a chronic kidney disease? You would expect an increase in their BUN, an increase in their creatinine. And so that's another big thing to think about that you could obtain from their BMP. And if you got a urinalysis, what could a urinalysis potentially show you? It could show you some protein within the urine. You'd actually have to follow it up with actually kind of like an albumin study. Or it could also show some red blood cells in the urine, some hematuria. So put all of that stuff together. These are the tests that you could utilize to think about a renal condition. All right, what about a cardiac condition? So how do we think it's coarctation of the aorta? Again, I told you, remember, think about the upper extremity blood pressures are going to be higher, lower extremity blood pressures are going to be lower. The other thing is, remember I told you that because the pressures are higher and you're filling the upper extremities and head and neck areas faster, and the actual lower extremities are going to get filled slower, you'll have the pulses of the brachial radial artery will come way before the femoral artery will. So there'll be a brachial femoral artery delay. The other thing is, if you wanted to get a chest x-ray, we talked about this a little bit in your acyanotic congenital heart disease, but sometimes there can be what's called rib notching, and you can chew away part of the ribs, and this can cause like a 3 sign, and sometimes the coarctation of the aorta, you may also be able to see the 3 sign present in coarctation of the aorta. But again, I think these are some of the big things to think about. All right, drugs. We talked about the drugs. It's easy, test for them. So if you think that they're utilizing some type of sympathomimetic that they should not be utilizing, like cocaine or methamphetamines, PCP, anything like that, get a urine toxicology screen. If you see that they're on oral contraceptives or NSAIDs, look at their medication list, ask them what they're taking, and that's a simple way to be able to rule out that. Endocrine, think about the adrenal issue. So there was high aldosterone. Guess what I can do? I can test aldosterone, my friends. And so if I think that the primary issue is an aldosterone, like as a tumor that's secreting aldosterone, I would check the aldosterone levels and they would be high. Here's one thing to think about. When aldosterone levels are actually high, it actually subsequently causes a reduction in renin production, because aldosterone will actually increase your blood volume and your blood pressure. What will the high blood pressure do to renin levels? Drop them. And so you would actually see that their aldosterone levels will be high and their renin levels will be low. Also, aldosterone does what to sodium? It increases sodium. What does it do to potassium? Drops potassium. So if you would also see this very classically on their BMP, where they would have a high sodium and a low potassium with high aldosterone and low renin levels. Big thing to think about. All right, what about the cortisol ones? Think about the moon face, the buffalo hump, the pendular, the basic obesity of the abdomen area, the striae. And then on top of that, you check their cortisol levels, and their cortisol levels are through the roof. 24-hour urine cortisol may actually be the test that you check here. All right, what about the pheochromocytoma, where they're blasting out tons of epinephrine and norepinephrine? They'll have paroxysmal headaches, hypertension, hyperglycemia, and a lot of anxiety and palpitations. What can I do? If I want to test for these little molecules, I can test for their breakdown products. And so I can do what's called a 24-hour urine metanephrine test, and those will be elevated in the urine, which is a lot of the breakdown products of epinephrine and norepinephrine. Also, the other thing is, because I told you they'll have hyperglycemia, look for elevated glucose levels. And if you really wanted to find a mass of their adrenal medulla, you can get an adrenal MRI. You can also get an adrenal image here for the hyperaldosteronism as well. All right, so these are the big things to think about. What about for the thyroid? Hypo, hyper. Just get the TSH with reflex. That'll tell you, right, if they have hypo or hyperthyroidism. No need to go down that rabbit hole. All right, what about the hyperparathyroidism? Check the PTH, check the calcium levels. You can even check the phosphate if you want, but if you check the PTH and it's super, super high, you check the calcium levels and they're super, super high, you have one of the reasons as to why this patient has that issue. And they may even have early osteoporosis. So that's another thing to think about. Pulmonary, they have obstructive sleep apnea, they're obese, they have a very large neck like me, okay? They have somnolence during the day, they're very lethargic, they snore, they wake up with a terrible headache. You get a sleep study and you find that they have obstructive sleep apnea. Boom, roasted. What about neurologically? Patient comes in, they has neurodeficits because they have a bleed of some kind. If they have a bleed, they have edema, they had some type of neurological injury of any kind, and now they're presenting with high blood pressure, bradycardia, and irregular respirations, and maybe they just have a severe neurological injury, so they're obtunded, they're stuporous, they're comatose. In that situation, you would think about a Cushing's type of triad from a neurological injury. And what would you do to find out what's going on in their brain? Get a CT or MRI to see what's going on. Do they have a bleed? Do they have a large stroke? Do they have just a lot of edema? Is there something going on there? So that's what I would do there. And pregnancy. Obviously, if it's a woman and you look at them, that may be one reason, but you should always never assume. Check a beta HCG, see if that's positive. And if it is, what should you be looking for? If a beta HCG is present and they tell me they're greater than 20 weeks, I'm worried about preeclampsia or eclampsia. Preeclampsia and eclampsia both had protein in their urine. So what would I check? I would check for proteinuria. So I get like a 24-hour kind of like urine study if I was concerned, but I could also just check a UA and see if there's a lot of proteins. If there is, I could follow up with like a 24-hour urine study to look for a lot of protein in the urine. And again, be very careful to watch out for any evidence of seizures that could be progressing into a patient who has eclampsia. All right, my friends, that talks about that secondary hypertension workup, which I think really kind of gives us a strong understanding and good space for repetition. For the complications, so a patient actually comes in and maybe they have one of the complications. What would I kind of test what I'd be looking for those? It's the same kind of concept here. If they develop a bleed, they develop a stroke, they develop PRES, they're having seizures, they're having neurodeficits, get a CT MRI. If they're having some type of issue where their urine output's decreasing, they have a bruit, something of that nature, you check a BMP, a renal ultrasound, and a UA. Their BMP may show that they have an increase in BUA and an increase in creatinine. The renal ultrasound maybe shows some type of like problematic issue here that we know about. And then a UA may show like hematuria potentially. Again, cardiac, if I'm concerned that maybe they have like an NSTEMI, or that they have like some type of issue here, like an atrial fibrillation that they went into, or like diastolic heart failure, I get an EKG. That'll tell me if they have any ST segment elevation or depression. I can get an echo to see if they have any evidence of heart failure, like diastolic heart failure. I can get a chest x-ray as well. A chest x-ray would always be helpful because what happens in diastolic heart failure, if they have very high blood pressure, they can have pulmonary edema. So get a chest x-ray to look for any evidence of pulmonary edema, and obviously check your tropes if your EKG is concerning for any kind of ischemic heart disease or any kind of issues like NSTEMI, STEMI. Vascular, if I'm concerned that they have like an aortic dissection because they have different blood pressures, ripping type of tearing chest pain, I could consider doing an abdominal ultrasound to look for, that would be more for a AAA. But if I'm concerned for maybe some type of aortic dissection, I can get an echo to see if it's like a proximal aortic dissection, or I can do like a CT angiogram to see if I can find some type of dissection as well. And then lastly, if I get my good old fundoscope and look at the retina to see if I see any kinds of retinopathy, that also be a good test to look for any complications. All right, we hit our complications. Now what we gotta do is we gotta take and put all this together and talk about the treatment. How are we treating hypertension? Because there's a couple different categories, so let's talk about that next. All right, so let's talk about the treatment of hypertension. So obviously in all patients, you should advocate particularly modifications within their lifestyle. Anything that you can potentially reverse or stop that could be worsening their hypertension, you should try to change. And so obviously if a patient is obese and they have a poor diet, you should be changing those things. And I think one of the most important things is weight loss. So weight loss seems to be the most effective measure. If you don't remember any of the lifestyle modifications, that's the most important one to advocate for your patients. But if you change a lot of these, you're also going to see a result in weight loss. So exercise, the DASH diet, low sodium diet, also reducing alcohol consumption, but smoking cessation is also a big one as well. So again, start these in all patients, regardless of them having hypertension or not. After you've done that, if you have a patient who's greater than 140/90, or they're greater than 130/80, but they have a lot of cardiovascular disease risk factors. Maybe they had a stroke at some point in time. They have diabetes. They have heart failure. They have coronary artery disease. They have peripheral artery disease. They had a stroke at some point in time. Whatever. They have particular risk factors, and their blood pressure is greater than 130/80. You should still start medications. Oftentimes when patients are like super high, like at least 15 to 20 millimeters of mercury greater than 140, one blood pressure medication isn't typically going to work, so monotherapy won't be good. So sometimes you may have to start with combination therapy right away. So that's a big thing to think about. We're going to talk about these like as initial drugs. One of the things I really want you guys to understand here is when we start these medications, you start at greater than 140/90, yes, or 130/80 with a lot of cardiovascular disease risk factors. That's definitely true. But if they're greater than 140/90, like 15 to 20 millimeters over that, initial monotherapy probably isn't going to work. You're probably going to have to at least start with 2 drugs. So what are these drugs that we should start in these patients? That's the question we should be asking. So there's first line medications and then there's second line. Your first line ones are your ACE inhibitors, your ARBs, your dihydropyridine calcium channel blockers, and your thiazide diuretics. So your ACE inhibitors, these are ending in pril, captopril, enalapril, lisinopril, all of those ones. Your ARBs, I like to actually clump them together. We're just going to have a little separate line here for them. That's your angiotensin receptor blockers, that's losartan and valsartan. These guys, both of them are really good. ACE inhibitors and ARBs are very good in patients with diabetes. They're good in patients who have chronic kidney disease. They're good in patients who have coronary artery disease. And they're good in patients who have heart failure, both ACE inhibitors and ARBs. One of the things I think is really important to watch out for with these drugs, especially with ACE inhibitors, is it can cause angioedema and dry cough. And so you might want to be a little bit careful in these patients who have some type of underlying like reactive airway disease, like asthma. Be very careful in putting patients who have asthma or maybe like some type of COPD of something of that nature on a drug like ACE inhibitors. ARBs don't really cause much of that angioedema or dry cough. So that's a big thing to think about. Okay, so those are the two drugs I really want you guys to think about. ACE inhibitors, ARBs, they really work on that renin-angiotensin-aldosterone system. So ACE inhibitor reduces the production of angiotensin 2. Angiotensin receptor blockers, they block angiotensin 2 at the receptor site. That's a pretty cool thing. So you'd use these in patients who have a lot of high amounts of renin as the cause of their hypertension. Now, dihydropyridine calcium channel blockers. These are very, very important ones. And this consists of amlodipine and nifedipine. Now, these ones are very, very interesting. They work at the actual vascular smooth muscle and they help to be able to relax the blood vessel. If you dilate or relax the blood vessel, you reduce the resistance to blood flow and that drops their blood pressure. These are very, very good in patients who have low renin hypertension. So their problem isn't an issue with renin, it's a problem where they actually have like more sodium retention. What kind of disease would that be good for? Patients who are African Americans. Why? Because African Americans have low renin hypertension. Their problem is not an issue with renin. So ACE inhibitors and ARBs would not be a good drug for African Americans. It would be dihydropyridine calcium channel blockers like amlodipine, nifedipine, that would be more beneficial for them. The other one is thiazide diuretics. So think about this. Thiazide diuretics are like, you have hydrochlorothiazide, chlorthalidone. They work to be able to excrete sodium and water from the actual urine, like in the urine. And so you reduce the sodium and you reduce the water within the bloodstream, which reduces the blood volume and reduces your blood pressure. But it's really getting rid of the sodium. And what kind of patients would this be beneficial for? Patients who retain lots of sodium. Who are your salt retainers? The patients with low renin hypertension. Who are the patients with low renin hypertension? African Americans. And so you would see this as being good in patients who are African Americans because they have low renin hypertension. And this is an interesting one. Osteoporosis. Why in the heck would thiazides be good in osteoporosis? You know what actually thiazides actually help to do? They help to absorb calcium. They increase the reabsorption of calcium in the bloodstream. And so if you have a patient who has osteoporosis who maybe has some lower calcium and they need more calcium deposited into the bone, guess what thiazides will do? Up your calcium and increase the calcium deposition in the bone. So think about that also in the exam question. I would be careful though to avoid this in a patient with gout because we've actually seen that thiazide diuretic can increase the concentration of uric acid. And uric acid is one of the problematic issues behind patients with gout. So be careful with that one. Okay, so I think we have a good idea. ACE inhibitors, ARBs, these are the ones who are good for diabetes, CKD, heart failure, and again, some type of CAD there. So we covered those. Dihydropyridine calcium channel blockers and thiazides, good for African Americans, low renin hypertension issues. Okay, second line medications. So this is your beta blockers. So these could be metoprolol, bisoprolol, carvedilol. There's tons of these different types. What I think it's important to remember is that these have actually been shown to reduce mortality and have been beneficial in patients with coronary artery disease. They can actually help with heart failure, and they've been shown to be effective at rate controlling, slowing down the heart rate in patients who have atrial fibrillation. And so these would be the patients that you want to think about in utilizing this. So if a patient has heart failure, consider this medication. They have recently had some type of like STEMI, consider this medication, or they have AFib and they have a high heart rate, consider these medications. Now, who would you be careful with in the clinical vignette where they said, ooh, should you give this or not? Be careful in patients with COPD and asthma because sometimes in these beta blockers, that are non-selective, they can bind onto the beta-2 receptors in the actual airways. And if they bind onto the beta-2 receptors in the airway, they can actually cause bronchoconstriction, which can worsen patients who have asthma and COPD. So just be cautious with that. It's not absolutely contraindicated, it's just something you gotta be careful with. If they have a super low heart rate, they're bradycardic, I'd be careful giving a beta blocker because that could lower their heart rate even more. We don't wanna cause them to lower their heart rate even more. That could cause like a syncopal event potentially. Decompensated heart failure. Whenever you have somebody who is actually in acute heart failure, all right, if they're in acute heart failure, their contractility maybe is decreased. If you give them a beta blocker, that's going to reduce their contractility even more. You reduce their contractility, you reduce their stroke volume, reduce their cardiac output, and you can drop their blood pressure. Also, if you drop their heart rate, that drops their stroke volume, drops their cardiac output, and drops their blood pressure. So just be very careful in patients who have heart failure with a reduced ejection fraction, giving them a beta blocker. Lastly, I would not say it's contraindicated, but I would be cautious in giving beta blockers to a patient who has hypoglycemia. You wanna know why? When a patient's hypoglycemic, guess what the reaction is to let yourself know, oh man, my sugar may be low. You start sweating, your heart rate increases, your blood pressure kind of goes up. You start developing sympathetic signs that your blood sugar is low. It's kind of alerting you, hey, you should probably check your blood sugar, buddy. If you give somebody a beta blocker, that blunts all the sympathetic responses, so they don't get the tachycardia, they don't get the sweating, they don't get the actual increase in blood pressure, and a lot of those signs that could be concerning of a hypoglycemic crisis. So it can actually blunt the hypoglycemic symptoms. So just be very careful in a clinical vignette with that. All right. The last second-line medication, I would not actually remember this if you don't want to, it's just we're putting it here for thoroughness, is the aldosterone antagonist like spironolactone. This is one of those that it's an add-on therapy that you can give to patients, particularly who have coronary artery disease, so they had an MI, or more specifically, they have heart failure. It's actually been shown to potentially reduce mortality in these patients. So that'd be something like spironolactone. One thing to be careful with in these drugs is that they do tend to retain potassium. They block aldosterone. So if they block aldosterone, aldosterone actually reabsorbs sodium and excretes potassium. If you block that, then you don't actually reabsorb sodium and you don't excrete potassium. So potassium can build up. So be careful with that drug when you have somebody who has hyperkalemia. All right, pregnancy. Is there particular types of measures that we should think about in this situation? There's 4 agents to use. You can remember this by the actual saying, healthy moms love nifedipine. Okay, so healthy hydralazine, that is an agent that is actually safe to use in patients who are pregnant. Methyldopa, labetalol, and nifedipine. These are drugs that have actually been shown to be safe in patients who are pregnant. The ones that you should be careful of and very, very significantly avoid because they're contraindicated is ACE inhibitors and ARBs. They've actually been shown to be teratogenic. And so that's a very, very important thing to remember for your exams. Do not give these medications to a person who's pregnant and who has hypertension. Thiazides, it's not necessarily contraindicated, it's just you should probably avoid it. And the reason why is if you give someone thiazide diuretics, you can drop their blood volume, and that may reduce the perfusion to the placenta. And that might be something that you definitely want to avoid as well. And so I would stay away from thiazide diuretics as well in these patients. But again, hydralazine is a direct vasodilator, methyldopa is an alpha-2 agonist, labetalol is a beta and alpha blocker, and then nifedipine is a calcium channel blocker. So these are the drugs that I would definitely give in these patients who are pregnant and have maybe some type of preeclamptic or eclamptic type of issue. These would be the drugs to utilize in that patient population. Okay, all the other ones, again, maybe a little bit different for anybody else outpatient. All right, the last one that we have to talk about is the hypertensive emergency. So remember in hypertensive crisis, there's hypertensive urgency. We don't really care about that one. It's the same thing. You treat it like you would any kind of medical management. It's when someone has hypertensive emergency, they have target organ damage, complications of hypertension. When that happens, we have to drop their blood pressure immediately with IV agents. We need IV antihypertensive. These are not going to cut it. We can use these later, but we need IV medications in hypertensive emergencies. Now, it's important to remember, this is very important for your exam. If they ask you when you drop the blood pressure, let's say their initial blood pressure was 220 over 140. It's pretty high, right? And they have damage. Maybe for whatever reason, they bled into their brain. They developed an intracerebral hemorrhage. If that's the case then, and you said in your report, how much do I want to drop their blood pressure over the next 2 days, you have to have this memorized. First thing, they come in, let's say 220 over 140 and they have a bleed, they have hypertensive emergency. Their blood pressure is greater than 180 over 120, and they have target organ damage, brain injury. If that's the case, you drop the blood pressure 25% of the initial blood pressure. So 220 over 140, drop it down 25% of that in the first hour. Okay, that's the first thing. Once you've done that and they've tolerated it, then you can move to less than 160 over 100 for the next 2 to 6 hours. Then after you've done that and they've still tolerated it, then you can slowly over the next 2 days get them down to their baseline blood pressure, maybe less than 140 over 90 or less than 130 over 80. That is how you should drop their blood pressure. Why am I saying that? Let's say you take them from 220 over 140 to 120 over 80 and you do that in an hour. You're going to drop their blood pressure precipitously that you can actually cause ischemic complications. You drop their blood pressure enough that now they aren't perfusing their brain, they develop a stroke. You drop their blood pressure enough that now they're not perfusing their coronaries, they develop an MI. You drop their blood pressure enough they don't perfuse their kidneys, and now they have an acute kidney injury. So it's very, very important to slowly decrease their blood pressure. And the way that we do this is with IV agents. There's a ton of these. I don't think a lot of these are worth remembering except particularly 2 because they're the most commonly utilized ones, and that's nicardipine and labetalol. These are the most commonly utilized ones. Also, other agents that could be utilized could be hydralazine. Esmolol seems to be somewhat beneficial in patients with like an aortic dissection. Nitroprusside, not commonly utilized as well. Nitroglycerin could be helpful in those patients who have like a left heart failure with a lot of pulmonary edema. Those may be beneficial as well, but most commonly it's going to be nicardipine and labetalol as the most common IV agents to get those patients controlled who have a hypertensive emergency. Now, engineers, we covered a massive amount of information about hypertension. It's a very important disease, a very common disease, and it's something that we should be able to recognize because it is the silent killer in these days and age. So please understand this, please know this. I hope it made sense. I hope that you guys enjoyed it, and as always, until next time.